bronchopneumonia, both lower and bronchopneumonia. So you have you have neutrophils present in exudates, and there's some periods in exudate, rich in neutrophils which fills the bronchioles and adjacent alveolar spaces. And bronchopneumonia rust, by looking at it grossly, you can see that there are gray patches on its location, and this appears either on one lobe or it can appear on multi-lobe. And that's bronchopneumonia. But they said lower and bronchopneumonia can be used interchangeably because it all depends on patient's immune system. You can a person with a weak immune system to get lower pneumonia, but a person with a strong immune system could get bronchopneumonia.
And what about the viral and the bacterial?
The viral. Viral is caused by influenza type A, B, adenovirus, rhinovirus, or chlamydia pneumoniae. And the lung involvement may be patchy or may involve whole lobes bilaterally or unilaterally. By looking at it grossly, the lung outside the surface of the lung is red, blue, and congested. And histologically, the alveolar septa are white and edematous and have a mononuclear inflammation. The infiltrate consists of lymphocytes, macrophages, and occasionally plasma cells. In acute cases, neutrophils may be present. When complicated by acute respiratory distress syndrome, histologically, have thin hyaline membranes lining the alveolar walls.
Yes. I had like different types of viruses and what happens with them. In general, when viruses cause pneumonia, it initially attacks the parenchyma, adjacent to external and respiratory bronchioles, and
You're
subsequently
competing with this thing here. Go ahead.
and subsequently progresses to involve the entire lobule. So with influenza and avian influenza pneumonias, the histopathology reveals edema, focal hemorrhages, and cellular infiltration. It's the presence of acellular hyaline membrane lining the alveoli, and avian influenza typically shows fulminant, necrotizing diffuse alveolar damage with patchy interstitial quasi-cellular fibrosis. Varicella zoster, measles, and CMV pneumonias. Varicella zoster pneumonia shows focal necrosis, consolidation, a mononuclear infiltrate through intracellular inclusion by this. Measles cause a predominantly interstitial infiltrate with mononuclear cells and multinucleated giant cells. CMV pneumonia demonstrates typical cytomegalic cells with intranuclear and cytoplasmic inclusions. And then the HSV and hantavirus pneumonias show parenchymal necrosis, hemorrhage, and mononuclear infiltrates.
Okay. So if you had to compare viral pneumonias and bacterial pneumonias, like microscopically, what would you say are some of the differences that you would find when you look under the microscope?
Well, viral pneumonia, there's neutrophils would normally be present.
That's right. So that's one thing, yeah.
We have two cases that neutrophils are present, but that's very rare.
Or it could be that neutrophils will come in as a secondary thing if you have bacterial infection afterwards, right? So where it goes. But go ahead. Go ahead with the viral.
It has lymphocytes, macrophages, and occasionally plasma cells.
Anything else?
There's TMB cells and there are plasma cells and the macrophages to destroy any extra, any dead tissue or infected cells.
I think like viruses bacteria seems to have more adenomatous, symptoms, while the viral ones have more cellular conditions, like giant cells and stuff like that.
I found that different bacteria that can be present with different symptoms.
Okay,
So like the Legionella, that's a bacteria. If the bacteria was abdominal
she
pain,
has to be.
Kind of.
Legionella, that's a bacteria. But if it was pneumonia, right, then it will present with abdominal pain, diarrhea, or confusion, and then streptococcus pneumonia is associated with a rusty colored sputum and Klebsiella pneumonia. You may have a bloody sputum. So like different bacteria.
Yeah.
So have different symptoms.
Okay, okay. And if you had bronchitis as opposed to pneumonia, what would be the difference?
But it's going to be very, not going to be like the amount you produce,
I don't know, I asked
the
you.
amount, well, the amount in bronchopneumonia, it's a mucociliary border that's going to be affected faster than the alveoli. So that,
Right.
so that you don't have the bugs of
Okay, so you have two different levels of which you
Yeah.
have the infection occurring,
Yeah.
right?
So one up versus third round.
Right. So bronchitis would be occurring in the tubules and in the tubes that transport the air
Yeah.
and oxygen, while with the pneumonias it will be at the alveolar level. So therefore, which one is more serious and how is there going to be a difference in presentation necessarily?
I just found a table just now. Can you read it?
Somebody else.
I also have the table. So I'll read that. Okay, so to compare the acute bronchitis and the pneumonia, we're going through some of the common symptoms. So the first one was cough. In acute bronchitis, you would usually have like a dry cough that would really be productive, whereas in pneumonia, you would usually have mucus that would be brought up from the lungs. After a few days of acute bronchitis, the cough may bring out clear mucus, but in pneumonia, it might be like green or tinged with blood or anything like that. In terms of a fever, in acute bronchitis or bronchitis on a whole, it would just be not present or it could just be mild. So a little bit above your normal 37.5, whereas a fever in pneumonia would be 38.5 degrees. And in terms of the diagnostic, X-rays would be normal for bronchitis, and bronchitis would just go away within 2 to 3 weeks. But in pneumonia, they're explaining that you have abnormal X-rays, and then you have a whole other sort of symptoms that are associated. So not like the typical ones that I was mentioning just now. You would have tachycardia, so your beats of over 100 beats per minute. You would breathe faster than 24 breaths a minute, and you would also have that sort of chills, and your teeth would be chattering just from being that sort of feeling of cold. And they said that it could last longer than the typical 3 weeks that it would take for bronchitis to disappear.
Okay, and what would your patients present with the pneumonia?
I guess the severe piece is complicated with pneumonia would be emptying, what they said is like once between not emphysema.
And
Yeah.
but the spontaneous actually fast and detect different environments of different pus in the parietal layers, especially the lungs and the pus in the parietal layers take a root without action. So we don't present
I had
Okay, but what would your patient present with
the coughing.
as opposed to you have the bronchitis and you have the pneumonia?
Yeah.
What would your patients present with? Yes, somebody. High fever and chills are what they would present with your pneumonias. And because you can't get propagaceous exchange, you will get cyanosis, you will get that kind of thing, you will get dyspnea and tachycardia to go with it. So those are some of the things that you would think of when you see your patients presenting with these things. Remember that at this level, I want you to think a little bit, well, I don't know what the university wants, but I would like you to think clinically. Okay, so So when you see that, those are and especially with children, the first thing that will come to mind, you see the chest, actually the chest will actually sinking in when they breathe, and you think that's the first thing you think that pneumonia. And when you see them in casualty, what are you going to do for them? What's some of the first things you do? You give them oxygen. What's the other thing? What will you be thinking of that they have in addition? They've been having fever, they are children, they will be quite likely dehydrated. Remember with children, it is very easy to also overhydrate them because they are small inside. So you don't rush in a liter of fluid and the next thing you send them with a heart failure. So well, if you get a pneumonia, you can get infections anywhere, and you can see into any organ, and so on. You can get meningitis, and sepsis, and endocarditis. But if you have
it depends on the bacteria. With a very virulent, remember very virulent, sugar bacteria can attach to the endocardial mold. Both.
Remember, you can get endocarditis with viral things as well.
Yes,
Remember, you can get endocarditis with viruses as well.
Yeah.
So don't think that it's only
Bacteria.
Alright, anything else? What else? You could get pulmonary
Edema.
what else? Embolus. Okay, so these are some of the things you have to think about.
The blood is
You have stasis in the lung and all that.
the factors are
Yeah, you have a lung that is full and is blocked here.
These I know along with bronchial pneumonia, well, bacterial pneumonia is heavier, like the viral bacterial.
Okay, so you all are happy with that? And the measures and recommendations for the prevention and control of influenza virus infection. Go to sleep.
controlling this part of infection is the most important. So measures to reduce spread of infection, wash your hands, to thorough and frequent washing hands is the best way to prevent any common infections. Scrub your hands vigorously for at least 15 seconds. Use alcohol-based hand sanitizers if soap and water aren't readily available. Contain your coughs and sneezes. Cover your mouth and nose when you sneeze or cough to avoid contaminating your hands. Cough or sneeze into tissue or into the inner of your avoid crowds during flu season. Flu spreads easily wherever people congregate. Example, childcare centers, schools, office buildings, or during public transportation. By
And
avoiding
old people's homes. But old people are at risk, so you have to be aware that once you have one of them with the flu or something, it's easy for them to spread it. So that's why I So you have early childhood centers that we are building a mile of, and then you have old people's homes that we are not building.
primary changes